Hello everyone, welcome to a new session in hematology. Today we are going to discuss one of a congenital disorder. Okay, as far as hemolytic anemias are concerned, this is one of the disorder which mainly affect the membrane of the RBC. So it's a red cell membrane disorder. It is none other than hereditary spherocytosis. So they will give a case scenario. We have a 17-year-old girl reported from a town in Rajasthan who came with complaints of generalized weakness, yellowish discoloration of eyes and skin in 6 months. So yellowish discoloration of eye means jaundice, probably hemolytic anemia. Decreased appetite, non-documented weight loss since 4 months. She also had exertional breathlessness and easy fatigability. That means she is having somewhat severe anemia. She had significant history of recurrent episodic jaundice at the age of 2 years. See, imagine from almost when she was after her infancy, she's having these problems. 6 years and at 12 years. The next most important point that you have to stress out here: her father suffered from jaundice 20 years back. Okay, which he had received treatment, but no records were available. Other 4 siblings were normal. See, all these are giving a clue about the type of inheritance. We know hereditary spherocytosis is an autosomal dominant type of inheritance. Yes. There is no past history of blood transfusion or hospitalization. So usually a history of blood transfusion, everything will be more favoring towards thalassemia, because thalassemia, the hemoglobin level is very low, that the babies or the child will be failed to thrive. Am I right? Yes. So examination reveals small and short stature, mildly pale and moderately jaundice. Spleen was enlarged 6 cm below the right costal margin. So the patient is having splenomegaly. So 6 cm means we can say it is like almost a moderate splenomegaly. Okay, yes. And the liver was not probably enlarged. Other systems were normal. So all these features help us to give our diagnosis as hereditary spherocytosis. So what are the points? Yellowish discoloration, splenomegaly, moderate splenomegaly, that is then exertional breathlessness, easy fatigability. Right from childbirth, what she's having recurrent episodes of such complaint she's experiencing, okay, earlier also. Then her father has a similar complaints, other siblings were normal. So it is an autosomal dominant type of inheritance. It is very clear from that. So the answer should be hereditary spherocytosis. Before going to hereditary spherocytosis, now I want to give you an idea about what are the different proteins which are present in the red cell membrane. Number 1, we have something called as 4.2, then ankyrin, band 3. So these are the various proteins, okay, which is present, and we have something also called as spectrin, alpha spectrin, beta spectrin and actin. So in this picture it is given. So it is the spectrin deficiency which is responsible for hereditary spherocytosis. Am I right? Yes. Whenever there is a defect in spectrin dimer interaction problem, we get hereditary elliptocytosis, and in hereditary spherocytosis we will have also problem in spectrin ankyrin interaction. Okay, if there is a structural defect in spectrin, we have something what we call it as hereditary elliptocytosis. Fine. Yes. So hereditary spherocytosis, it is an inherited hemolytic anemia, okay, which will lead to microspherocytosis, splenomegaly, intermittent jaundice. These are the 3 important points you have to keep in your mind. Fine? Yes. And we will see that osmotic fragility, which is a test which helps us to diagnose this hereditary spherocytosis, it will be increased. Okay? Yes. So coming into hereditary spherocytosis, remember the most common abnormality you can get in case of hereditary spherocytosis, the answer is beta spectrin deficiency. Fine? Yes. So the mutations of this beta spectrin gene and point mutations which affect the binding of spectrin to protein 4.1, all these are most commonly implicated. So if they ask in multiple choice question, what is the most common cause of the mutation which is involved in case of hereditary spherocytosis, you can go boldly with the answer beta spectrin deficiency. Fine? Yes. So whenever there is a mutation ankyrin gene, it will lead to ankyrin deficiency. Then I told we have protein 4.2, band 3 proteins, all these. And remember, hereditary spherocytosis, in most of the cases, it is an autosomal dominant condition. We have autosomal recessive pattern also. But remember, hereditary spherocytosis, which is associated with the beta spectrin deficiency, is always autosomal dominant. At the same time, when the hereditary spherocytosis is associated with the protein 4.2 mutations, it is having an autosomal recessive pattern. All these are some high yield points. Okay? Yes. Okay, then coming to what is the mechanism of hemolysis in hereditary spherocytosis. See the spherocyte, you know what is spherocyte? If you don't know, please go and watch my video on abnormalities in peripheral smear. In that I have very well explained what is spherocytes and all the different morphologies of RBC. So I don't want to repeat the same points again. So the spherocytes of hereditary spherocytosis have reduced deformability and reduced membrane plasticity. You know, normally RBC is biconcave in shape. This biconcave nature of the RBC help the RBCs to go very smoothly within the blood capillaries. When this RBCs lost this biconcave, it becomes spherical. Okay, what will happen? It will get dislodged within the small capillaries, and which will leads to thrombus formation, which will leads to anemia. Fine. Yes. So see, the red cells have difficulty in passing through the interendothelial fenestrations of sinusoids of the spleen. Am I right? Yes. And these spherocytes get trapped in the spleen. That is the reason for splenomegaly. And the most important treatment. So in case of hereditary spherocytosis, we will always prefer splenectomy. Fine. Yes. See, this is the normal. There is a loss of membrane fragment. Finally, because of the defect in the membrane, what will happen? The biconcavity of the RBC will be lost, and so what will happen? The RBC will undergo some conformational changes. So the biconcave RBC now becomes a spherocyte, and these spherocytes will get entrapped within the splenic sinusoid, leading to splenomegaly. That is why splenectomy is the treatment of choice in case of hereditary spherocytosis. Okay. Now let us see what is the mechanism of hemolysis in hereditary spherocytosis. Hereditary spherocytosis will be asked as a short note question for you. Okay, you can't expect as an essay question, but as a short note question, they will give this clinical case scenario. So if you know these basic points itself, you can write. Fine. Yes. So what happened? This spherocytes, I told you, it has reduced deformability. So it can't change the shape, or it can't go very smoothly through the blood capillaries. It will have a greater internal viscosity and reduced membrane plasticity. So difficulty in passing through the interendothelial fenestrations of the splenic sinusoids. So the red cells become conditioned like spherical, and it will become more fragile. It will be phagocytes. So fragile RBCs will be always phagocytosed by the reticuloendothelial cells of the spleen, which will lead to increased extravascular. Why extravascular? Because hemolysis is taking place in the spleen. So because of this phagocytosis of the spherocytes by the reticuloendothelial cells of the spleen, we have splenomegaly, and because of the increased extravascular hemolysis, we'll have anemia and reticulocytosis. Or at the same time, so that is the one pathway. What is the second pathway? This is the first pathway. And what is the second pathway? The lactic acid get accumulated around the RBCs, which will cause inhibition of glycolysis. ATP generation won't happen. Then failure of sodium potassium pump. So there will be swelling. That is there will be more retention of sodium and water within the RBC, leading to abnormal RBCs, and this will be again phagocytosed by the reticuloendothelial cells lining the sinusoid, which will also cause increased extravascular hemolysis. That can also cause reticulocytosis. I told always hemolytic anemia. Just remember a very important point, that is increased reticulocyte count and anemia. So coming into the clinical features, see, because these clinical features are very important, because it helps us to make the correct diagnosis from the case scenario. Number one, remember, it is present usually in the neonatal period. Okay, yes, and the patients will have symptoms. Okay, that's recurrent attacks or recurrent episodes of symptoms right from the childbirth, and anemia will be usually mild to moderate. And remember, very very important point, intermittent jaundice. See, this is a characteristic word you have to search for in the case scenario if you want to make it the diagnosis of hereditary spherocytosis. Intermittent jaundice. Fine. Yes. And splenomegaly is a constant feature. I told you what is the reason for splenomegaly. Fine. Yes. So coming to the hematological finding, the first thing remember, it is spherocytes, that is microspherocytes, that is small RBCs without any central pallor. You can see in detail about, I told you that spherocytosis means don't always suspect hereditary spherocytosis. If you are seeing microspherocytes in a peripheral smear, the first thing which should come into your mind is autoimmune hemolytic anemia, because hereditary spherocytosis is not that much common. That's not the case with autoimmune hemolytic anemia. It is very common. Okay, so I have told you, that is the first thing you have to do. Once we rule out autoimmune hemolytic anemia, we have to always think about hereditary spherocytosis. Fine. Yes. Okay, so here, and remember, how will you differentiate the spherocyte? I told you spherocytes are present in both hereditary spherocytosis as well as in case of autoimmune hemolytic anemia. Then how will you differentiate the spherocyte which is present in these two? Remember, unlike in autoimmune hemolytic anemia, in hereditary spherocytosis, these spherocytes are uniform in size, uniform in density. Okay, that is a very very important. Yes, and based on the number of spherocytes, this hereditary spherocytosis can be classified as mild, moderate, moderately severe, and very severe. I have already told you we can also observe polychromatophilia. I told you what is polychromatophilia. It is mainly because of the reticulocytes. Okay, and we can also see some pincered cells, also called as mushroom shaped cells. Okay, fine. See, these are the spherocytes. Fine. Yes, and we can also see what these are the polychromatophils. These are the polychromatophilia. Okay, you can appreciate the polychromatophilia. Fine. See, what is this? Reticular circle 1, 2, 3, 4. See, on a peripheral smear itself, you can see more than 5. What is the stain? Brilliant crescent blue. Okay, or yes, brilliant crescent blue, supravital staining. Yes, we have mild, moderate, moderately severe, and severe. Fine. So all this based on, just remember, spherocytes. Few spherocytes, 1 plus, 2 plus, 3 plus. Okay, yeah. So osmotic fragility is the final test of confirmation. That's not the gold standard test. I will say that later. Okay. Remember, osmotic fragility is distinctly increased because you know what, the RBCs is almost swelling. Am I right? Yes. There will be what increase what water content within the RBC, and at the same time it lost its membrane, so it becomes more fragile. That is why osmotic fragility is increased. Fine. Then coming into MCV. Remember MCV. Okay. Yes. See, usually remember the MCV. Coming into mean corpuscular volume and MCHC. Remember, MCHC will be usually very high. Okay, MCHC will be what? MCHC is usually, I told you what is MCHC, mean corpuscular hemoglobin concentration. Okay, so actually there is only one condition in the whole hematology which I will say MCHC is increased, that is more than 36 gram per deciliter. The answer is hereditary spherocytosis. In less all this, I told you know, we have microcytic hypochromic, we have nomocytic nomochromic, we have macrocytic hypochromic, but I don't told that there is something called as what to say macrocytic hyperchromic. There is there does not exist any entity, we call it as a hyperchromic. Why hyperchromic does not exist? Because we have a blood cell indices called as MCHC, mean corpuscular hemoglobin concentration. It is because of this MCHC blood cell indices what the hemoglobin, what the RBC has an inbuilt mechanism to prevent the overaccumulation of the hemoglobin. That is the reason. Except in a condition, hereditary spherocytosis, MCHC is increased. And remember, MCV is decreased. Why MCV is decreased? Because see, microspherocyte, the MCV will be low, whereas reticulocyte, the MCV will be high. So overall, the mean corpuscular volume, no, the MCV will be in the normal range. So just remember that the MCV is almost in the normal range. It is in normal range. Fine. Yes. Then bone marrow shows erythroid hyperplasia. Fine. And a normoblastic reaction. Serum bilirubin is increased. I say, know all this. Why it is a hemolytic anemia. Serum bilirubin will be increased. Yes. Next, tell what happens to the serum haptoglobulin. It is reduced. Why? Because it is an extravascular hemolysis. Urine urobilinogen, cercobilinogen, all this will be increased. LDH will be increased. Direct Coombs test will be negative. So this is, I told you, when you are suspecting microspherocytes, immediately order Coombs test, because Coombs test will differentiate between HS and that is hereditary spherocytosis and autoimmune hemolytic anemia. Serum LDH level is also high. And the gold standard test is EMA, that is eosin 5 maleimide. Okay, yes, which binds to the band 3 protein of the red cell membrane. It's the sensitive and most specific test for the diagnosis of hereditary spherocytosis. Fine. See, this is the EMA binding test. We can see here the mean corpuscular okay, yes, see, yes, you can see the binding. Fine. Yes, there is no need that you should know how to appreciate this. Just remember that it is the eosin 5 maleimide. This question has been asked in names few years back, but it's the gold standard test for the diagnosis of hereditary. Suppose if eosin 5 maleimide is not available in option, okay, it is actually based on flow cytometry. Okay, I'm writing here FCM, flow cytometry. Fine. Yes. And if that is not in the option, we will have to search for another option. That is what we call it as osmotic fragility test. Okay, osmotic fragility test. As you can see here, this is the normal range of osmotic fragility, and it is increased in case of hereditary spherocytosis. See, this is, you can see erythroid hyperplasia with a normoblastic reaction. Okay, erythroid hyperplasia in the normoblastic reaction in case of bone marrow. Fine. Yes. So see, yeah. See, normal, what is the normal range of fragility of RBC? Normally, the fragility RBCs undergo fragile, okay, at 0.6 to 0.85% of hemolysis, okay, yes, normally no hemolysis occurs at 0.6 to 0.85%, whereas in case of what hereditary spherocytosis, the RBCs will be so fragile that at a very lower concentration itself, it starts to rupture. Fine, but the sensitivity is very poor, so we always prefer for flow cytometry. That is the gold standard for diagnosis of hereditary spherocytosis. Fine. And then what are the other tests? We can go for STS page analysis of red cell membrane, glycerol lysis test, ECTA cytometry test, not that much useful. Okay, yes. In hereditary spherocytosis, we have something what we call it as a hemolytic crisis and a hypoplastic or an aplastic crisis. Just remember, hemolytic crisis means following, so the patient is having hereditary spherocytosis, the patient is acquiring some viral infection. Following the viral infection, there will be rapid fall in the hemoglobin, there will be rapid increase in the reticulocyte count and rapid increase in the serum bilirubin. This is called as hemolytic crisis. This hemolytic crisis is almost similar to that of the hemolytic crisis in case of sickle cell anemia. Okay, sickle cell anemia, that is following a parvovirus B19 infection. And we have something called as hypoplastic or aplastic infection. as I told you, aplastic or hypoplastic is following the parvovirus B19 infection. There will be, so this parvovirus B19 is going to mainly affect the bone marrow. So because of the hemolysis, the bone marrow will always try to do what we call as erythroid hyperplasia for compensation. But here there is no compensation because the bone marrow is already being attacked by the parvovirus B19. So there will be reticulocytopenia. Initially there was reticulocytosis, now it become reticulocytopenia belonging to the fall in hemoglobin. Fine, and bone marrow demonstrates giant pro-erythroblast with the vacuolated cytoplasm. This is characteristically what we call it as the cytoplasmic protrusion. As you can see in this picture, what is this called as dog ears? Okay, what is this called as dog ears? Okay, these are the cytoplasmic protrusion from the giant pro-erythroblast. So once this is done, the differential diagnosis, as far as differential diagnosis is concerned, the first most important differential diagnosis for hereditary spherocytosis, autoimmune hemolytic anemia. How do you differentiate IHA from HS? The answer is Coombs test. Whenever you take a peripheral smear, whenever you are seeing microspherocytes, we can't appreciate whether it is uniform in dynasty, and it's just only for theoretical purpose. Immediately we have to order the direct Coombs test, and we have to see whether the Coombs test is positive. If Coombs test is positive with the spherocytes in peripheral smear, our diagnosis is autoimmune hemolytic anemia. Fine? Yes. Okay, see spherocytes in peripheral blood smear, we have to see reticulocyte count. If the reticulocyte count is high, we have to do Coombs test. If the Coombs test is positive, our diagnosis is immune mediated hemolytic anemia. If it is negative, we have to do osmotic fragility test. If it is positive, it may be hereditary spherocytosis, and it has to be finally confirmed by eosin 5 maleimide. Remember, EMA test is only positive for hereditary spherocytosis. It is negative in case of what we call it as hemolytic anemias. Okay, suppose if the reticulocyte count is associated with Heinz bodies. Heinz bodies means we have to search for bite cells, and we have to see for G6PD assay, that is G6PD deficiency. Heinz bodies are characteristic findings of G6PD deficiency. Fine, yes, that we will see in the next. Then I told what is the most important treatment as far as this is concerned. Splenectomy is done, but before splenectomy we have to give almost all vaccines against capsulated organisms like pneumococcal pneumonia, meningococcus, Haemophilus influenzae should be given splenectomy. After post splenectomy, what is the, this is a question I'm asking you, what is the peripheral smear finding you will get in case of post splenectomy smear? Yes, answer is Howell Jolly bodies. I hope you remember that point. Yes, Howell Jolly bodies. Yes. So with this we have finished hereditary spherocytosis. See, it's a very interesting topic. Fine. Yes. See, so once again go back to our case scenario. See, intermittent recurrent episodic jaundice, decreased appetite, there is easy fatigue, anemia, yellowish discoloration, jaundice. Then they have given a family history, so suggesting autosomal dominant type of inheritance. Her father is having episodes moderate jaundice, intermittent jaundice, then splenomegaly. Treatment of choice is splenectomy. Your diagnosis hereditary spherocytosis. Thank you.